Welcome to Medical Education Principles Lesson 2, Educational Psychology, Optimizing Experiential Learning. This is David Lee Gordon, Professor of Neurology. At the end of this presentation, the participant should be able to define the 4 educational psychology concepts key to optimizing experiential learning and describe the hidden curriculum and its potential positive and negative effects on learners. A key to optimizing clinical medical education is to flip the paradigm. Change from a physician who teaches to an educator who practices medicine. Content knowledge does not make one an effective educator automatically. The effective educator understands basic educational psychology principles and utilizes them when conveying that information. As we discussed in Medical Education Principles Lesson 1, the neuroscience of learning, optimal learning by trainees requires instructors. Furthermore, experiences by the trainees result in optimal learning if the instructors provide focus, preparation, motivation, and feedback. The educational psychology concepts that correspond to these 4 essential components of trainee learning are curriculum alignment, which provides focus for the learner. Priming, which provides preparation for the learner. Flow, which provides motivation for the learner. And deliberate practice, which is a form of experience with integrated feedback. These 4 concepts are interdependent and require a standardized didactic curriculum coordinated with an experiential curriculum and guidance from instructors. We will discuss all 4 concepts in detail in the following slides. Curriculum alignment is an optimal way for instructors to provide focus for the learners. Curriculum alignment refers to the process of linking objectives, assessments, and learning experiences to ensure learners achieve what is expected of them. In this model, learning objectives are not tacked on at the end, they actually drive the train. The learning objectives give purpose and focus to the learner, and then the assessments then must be linked to those objectives so that you assess what actually was taught, and the learning provided by the instructors must match the objectives and assessments. The famous quality improvement pioneer W. Edwards Deming once wrote, "You can expect what you inspect." And the medical education research pioneer George Miller once wrote that assessment drives learning. So in essence, you use the assessments to motivate and focus the learner. Now, this concept of curriculum alignment can only occur within a standardized didactic curriculum so that the learners and the instructors all are on the same page, lining up objectives, assessments, and learning. Optimally, you should use a blended learning environment with varied strategies, because learning objectives are not just to know things, but sometimes to do things. And if that's the case, then some of your strategies would be perhaps knowledge-based, lectures, for example, or readings, but other might be skill-based, such as using simulation. Curriculum alignment utilizes curriculum teaching to teach to the test. We want to teach to the test, but it's called curriculum teaching, meaning that you teach, you tell the learner exactly what topics they need to know, for example, or skills they need to do. Not item teaching. We don't say the answer is, A or B. It's not like that. There are those who think curriculum alignment is teaching the test in a negative way. It is not. It is teaching tests in a positive way. You're using assessment to drive learning. And you should assess all 4 types of learning objectives: knowledge, skills, attitudes, and behavior, which sometimes is abbreviated KSAB, to achieve mastery. This concept of curriculum alignment has a very positive effect on learner growth, satisfaction, and flow. We will describe flow in more detail in following slides. Priming is a way for instructors to provide preparation for learners. Priming refers to influencing learners' responses to an experience by first exposing them to related stimulus, such as a didactic session or case-based learning or simulation exercise before they go see a patient. Priming allows learners to avoid missing learning opportunities. It expands the knowledge base or experience of the learner in preparation for the upcoming clinical experience. This lessens the anxiety of the learner because they know what to expect and know what they're looking for, and it optimizes learning during the experience. It utilizes certain mental shortcuts, such as the framing heuristic, teaching words to guide thinking. Using key words to prime the learner enables them to find what they're looking for. It avoids the availability heuristic. The availability heuristic is when you generalize based on lack of knowledge. If you don't know about a condition at all, how can you take a history on that condition or do an exam looking for that condition? It avoids the interpretation bias, which is misinterpreting ambiguous information. If you don't know anything about a condition and you observe, you may misinterpret what you're observing. You need to be able to interpret what you're looking at properly. The experienced clinician looks at a patient, takes a history, does an exam, and interprets it correctly because they know what they're looking for and what the pattern is. Didactic curricula are formal priming exercises, but they are most effective when coordinated with experiential curricula, act as priming for preparation for the clinical experiences. They are not to be thought of as a separate entity. They are related to the experience of the learners. Flow is a psychology concept developed by Mihai Csikszentmihalyi and described in detail in his book published in 1990 called Flow, the Psychology of Optimal Experience. Flow refers to the state of optimal experience or enjoyment and maximal concentration. And Csikszentmihalyi found that this was achieved when a learner perceived that their skills matched their challenge difficulty. And he found that it only occurs in a structured system with feedback, facilitated by the didactic curriculum, for example, priming, curriculum alignment, and deliberate practice, which we'll describe later, and found that it cannot be achieved by independent experiences. If you look at the graph in the upper right corner of this slide, challenge on the y-axis, skill level on the x-axis, when a learner has a new challenge and their skill level is low, they are in anxiety zone and don't feel comfortable. As they gain their skills, they shift down the x-axis into the flow channel. If it is too easy a task, if their skill level is too big, too good for the challenge, they're bored. So the optimal experience has that balance that the skill level of the learner matches the challenge. Now this is obvious if you consider things like playing a musical instrument or playing a sport. The first time you play a musical instrument, you don't want to do it. It's very difficult and it's anxiety producing. Or the first time you learn how to play a sport, it's same concept. And then all of a sudden one day after you've been telling your mother you don't want to play the piano at all, she finds you playing the piano. And you say, oh, what? She says, well, what do you mean? I thought you didn't like the piano. Oh no, Mom, I love the piano. So after you've been taught and have grown in your skills at the piano, suddenly you like playing it on your own. Or you suddenly like playing tennis or golf or basketball or whatever sport it is on your own. That is the same in all skills. So this is true even in medicine. You start as a medical student, you're anxious, you don't know what you're doing, you gain new skills, and boom, you're in flow channel and you like it. And then you are all of a sudden an intern and you're having your anxiety. Oh, wait a minute, but now you gain new skills and you get into flow with time and feedback, priming, et cetera, et cetera. So this is called flow. And every learner must be told that you need to just be patient with yourself because you will shift from anxiety into flow. So this concept of flow provides a sense of accomplishment. You feel like, okay, I know what I'm doing when you are in flow. And it facilitates continued growth. If you look at the graph in the bottom right corner, the novice, for example, the medical student, is anxious but then learns enough to be in flow for their level. And then the resident gets out of flow and anxiety, but then they get new knowledge and they're in the intermediate level and they are in flow. And then they become an attending, for example, and then they're out of flow, their anxiety, and then they, with more skills, get into the flow again. If you gradually increase the challenge difficulty to match the skill level together, this will happen seamlessly. One of the challenges is that the learner must not perceive anxiety as a pathologic process at all times. There is such a thing as a physiologic anxiety. And so anxiety has to motivate and not disable. It's important that the instructor give the learner confidence by saying, hey, this is going to get better. This is going to be better. You will get into flow. Just continue with the process. As some have said, trust the process. Deliberate practice is an educational psychology concept developed by Anders Ericsson, the late professor at Florida State University. This is a system for providing experiences led by instructors. Anders Ericsson referred to deliberate practice as focused, repetitive practice designed by instructors to improve performance of specific tasks. And he found this concept was necessary to advance to the level of expert. So W. Edwards Deming, the quality improvement expert we quoted before, once wrote, experience itself teaches nothing. And so Anders Ericsson found, okay, he's right. It took 10,000 hours of deliberate practice to lead to expertise. Now, you may have heard of 10,000 hours of doing something makes you an expert, as popularized in some of the lay literature. That is misleading. 10,000 hours of seeing patients does not make you a better doctor. 10,000 hours of playing tennis does not make you necessarily a better tennis player, actually. The best players, tennis players in the world, golfers in the world, basketball players in the world, etc., musicians, all have people guiding them. You have coaches you do drills with the coach and you prepare, and then you get feedback from your coach after the experience. For some reason in medicine, we think that if you just go see patients, you're a better doctor, but that is not true. You need the feedback concept and you need the preparation concept. The 5 essential components of deliberate practice, in fact, are a motivated and attentive learner, well-defined tasks and goals, appropriate level of difficulty, informative feedback from the instructor, and opportunities for repetition and refinements. And note that the didactic curriculum specifically provides the motivation and attentive learner, the well-defined tasks and goals, and the appropriate level of difficulty. It helps you get a jump start on the experiences. If you look to the right in this graph here, comparing learner growth on the y-axis and experience on the x-axis, you can see that just practicing, just seeing patients, for example, does not actually lead to growth. It requires this concept of deliberate practice. Then you lead to growth. What Anders Ericsson said, is you can't find something you know what you're looking for. He wrote, when most people practice, they focus on things they already know how to do. But research has shown that it's only by working at what you can't do you turn into an expert. How do you know what you can't do? You have to be led by an instructor. That is an essential component of gaining from your experiences. Another important concept to consider when optimizing experiential learning is aligning the declared and hidden curricula. The learning environment, which is all the circumstances and influences surrounding and affecting a person's learning, consists of the sum of declared and hidden curricula. The declared curriculum is the formal curriculum promoted by the institution, especially in classrooms and skill centers, and theoretically anyway, represents ideal practice. The hidden curriculum is informal learning. that differs from the declared curriculum, and it especially occurs in clinical settings, and it comprises actually the majority of experiential learning. It represents real-life practice and thus is not always ideal. However, when consistent with the declared curriculum, in other words, curriculum alignment occurs at this level where the declared is aligned with the hidden, it actually reinforces or enhances the declared curriculum. It's a positive. However, when it is inconsistent with the declared curriculum, this hypocrisy leads to learner confusion or ignoring of the declared curriculum. So mostly when people consider this, learners or instructors, they're thinking about professionalism, where you say to the learner, this is how you should behave in a certain way, and then they go into real life and things are not that way. But it's more than that. It also refers to even skills or techniques or other knowledge that the clinician who is not aware of the didactic curriculum, may say that contradicts the declared curriculum. It is completely good and normal and excellent and improves education when you enhance the declared curriculum. If the instructor on the wards, for example, in the inpatient setting or in the clinic says, what you learned about X, Y, and Z is excellent, but let me tell you some new skills on top of that you can learn. Or that's true, but let me tell you why sometimes it varies because real life is not always what you learn in the classroom. That's fine. But when the clinician teaches the learner, oh, what you've learned over there is wrong, or directly contradicts, or behaves in a way that is directly opposite of what was taught as the optimal way to behave to the learner in the declared curriculum, then it becomes a form of curriculum disalignment and is actually harmful to learning. For this reason, clinician educators really should know the declared curriculum so that this facilitates their supplementing and not contradicting the declared curriculum. This concludes Medical Education Principles Lesson 2, Educational Psychology. At this point, you should be able to define the 4 educational psychology concepts key to optimizing experiential learning, and you should be able to describe the hidden curriculum and its potential positive and negative effects on learners. Thank you for viewing and listening to this presentation. This is a DLG Insight production. Innovative neuroscience ideas and thoughts on education.